I'm Jim Eisenach. We're in San Diego for the 2010 annual meeting of the American Society of Anesthesiologists, and it's my privilege and honor to interview as one of this year's Wood Library Museum Living History honorees, Francis M. James III, or Frank James, or Frank as I've called him since I have known him since 1985. So Frank, I wonder if you'd begin by telling us a little bit about your early life before you got into medicine.
Well, I grew up in Philadelphia, Pennsylvania, and my schooling was all there. My father was a general practitioner in medicine and had only been out of his internship for a few years when Second World War came. So he ended up enlisting in the Navy and doing that for 5 years during the Second World War, and I stayed in Philadelphia with my brother for our schooling and just continued on until I finished my residency at the University of Pennsylvania, and a year later moved to North Carolina.
So you were in Pennsylvania growing up and through all of your schooling?
Correct. Stayed in the same school first through 12th grade. It was a friend school, Friend Central School. Really wonderful thing. When I went back for my 50th reunion, I think we'd had 52 or 53 graduates. 7 had died. We had 39 back out of that number, and then you added in spouses, it was more. And that was a very formative part of my life. And then I went to college there as well at Swarthmore College.
Now you've maintained an interaction with the schools that you went to and have actually been a leader at those schools from afar, haven't you?
I have, particularly with Swarthmore College. I was on the Alumni Council for a number of years and president of the Alumni Council, which put me on what was called their Board of Managers, which is like the Board of Trustees, for 2 years. So was involved, and then all 3 of our children went to Swarthmore. So again, I kept being involved during that time. And in fact, my older granddaughter, who's a senior in high school, has applied to Swarthmore, and if she goes there, she'll be the 14th member of our family, either somebody who married into it or actually, a person of blood relative who went to that school.
So I bring that up, Frank, because in looking at your CV and in knowing you the way I do, it's very clear that you've been involved in the community at school and elsewhere in very many ways. And I wonder if you could tell us a little bit about when that started. As far as the involvement in the schools concerned? Or community. In community. Well, in the schools, after I graduated, I kept touch with the place I went to school first through 12th grade just because I was living in the Philadelphia area. And then with the college situation, I was elected to the Alumni Council after we had moved to North Carolina and spent, I guess, 9 or 10 years on that and was president of it for 2 years. And the fact that our 3 children all were there in school also helped me to be involved with the school and get to know what was going on there a lot. It reconnects you when you go back after you've been away for a while. So could you tell us a little bit about going into medicine, what led you towards medicine and what led you specifically towards anesthesia? Well, I'd start out by saying that my brother, who was almost 3 years older than I am, and I both swore we would never become physicians. And that was because we saw how hard my father worked as a general practitioner of medicine, and his brother, who also was a general practitioner. They were in solo practice in the Philadelphia area, and my dad never took more than a week's vacation all the way through the time that I was in medical school until after that time. He also did not ever want to leave his patients. He worked till about 11 o'clock every night of the week except Sundays and Saturdays. So there was no way that I was going to do that or my brother was going to do that. But my brother switched out of engineering when he was in college, and I thought I was going to go into business, but found out that I really struggled with my economics class in my freshman year, and subsequently on some aptitude testing learned that abstract thought was not a strength for me. And I also love biology, so I switched over to medicine too.
So Frank, I've known you a long time, and I hear themes there that resonate with me. The focus and learning about economics as a chair of a department and as a leader in our specialty. And when you mention aptitude, the role of personality type, and one of the things I recall as a faculty member in your department was retreats where we would try to understand how we communicate. And I wonder if you could describe that and how you've applied that, not only within our department, but as you've applied that as a leader in other societies within anesthesia.
One of the things that causes people to fail in adult life, whatever their endeavor might be, is the failure to communicate. And I think I learned that pretty easily early in life when I watched my brother who didn't communicate too well with my parents, and I learned what not to do through observing what he did do. And I've found that if I can get to know people and to know, where they're coming from on various issues and why they think the way they do, such things as the Myers-Briggs study, which I know you've done, which looks at personality types and how people see the world, it doesn't mean that I'm right and you're wrong. It just means that we may look at the world differently, and I think that's really helpful to understand that people aren't trying to be difficult. They genuinely see things differently sometimes. And Jim, I've always been one too who has looked at the world and people as gray as opposed to black and white, and that helps me to again try to listen to them and understand what it is they're trying to say to me. So I think communication is important, and I think listening to people is important. I can remember talking with our chair of radiology, Doug Maynard, who is about the same age that I am, and our careers pretty much paralleled each other at Wake Forest. And one time I went to see Doug, and we were talking, I can't remember what it was about, but he said, "Frank, don't you ever feel when a faculty member comes in and has this problem and complains about it, don't you ever feel like saying to him or her, that is not an important issue in the greater order of things and what I'm dealing with as a chair or the school or the world?" And you do feel like that, but you can't say that, and Doug and I discussed that because to that person it's a big issue. So I think it's trying to listen to people and understand them and work with them.
So Frank, let's move on to anesthesia. You've contributed to several areas of anesthesia. I think of obstetric anesthesia, the AUA, being a leader in several parts of the anesthesia world, and contributing to leadership of our specialty as well in the American Board of Anesthesiology. So let's go through those a little bit. And maybe to begin with, why don't you tell us a little bit about moving from Pennsylvania to this little town of Wake Forest, or little town of Winston-Salem, and Wake Forest University, and how you moved from there to becoming the chair of the department.
I did my residency at the University of Pennsylvania from 1964, you might say through 66, because in those days, as you may recall, Jim, you did an internship and then 2 clinical years of anesthesiology. I did a 3rd year that was a sort of fellowship semi-faculty time where I was paid halfway between what a faculty level of pay would be and a 3rd year resident would be, or 4th year resident. And then I was asked to stay on the staff at Penn, which to me was I couldn't believe it. I mean, Dr. Drips was such a hero of mine, and I thought the department was such a great one back in the mid-60s. And I did stay for that year, and growing up in Philadelphia, I just envisioned myself as staying there the rest of my life. I'm still root for the Phillies and the Eagles and all the various Philadelphia teams. I'm still tied to Philadelphia in those ways. Well, in 1967, Tom Irving became the head of the section of anesthesia in the Department of Surgery at Wake Forest, then called the Bowman Gray School of Medicine of Wake Forest College. And Tom asked me to come. I came down and looked in the summer of '67, and it was pretty funny because my wife grew up in Martinsville, Virginia, which is about 50 miles north of Winston-Salem. She used to come with her family on Saturdays to shop in Winston-Salem, and when we got there on a Sunday morning in 1967 and had driven around the downtown area in probably less than 5 minutes, she kept saying, I know it's bigger than this. I know it's bigger than this. There just wasn't anything there, and nobody was around or about downtown. Town was about maybe 125,000 people. Then we went over and looked at the medical school and the hospital. Hospital was 300 beds. The Reynolds Tower hadn't even been built yet. That was built around 1974, 75. There was a gravel parking lot there. It was flat out depressing. The department had been small. The chair of the section, actually, Roy Crandall, had died unexpectedly, and Tom had been brought in there to really help them address the clinical needs and to begin the teaching programs. And he had asked me to come help with that. I did not come that first year. I can remember going through about 3 months when I really had trouble sleeping, not knowing what to do. Finally decided to stay at Penn. But a year later, when Tom asked me to come again, I said yes. And part of it was leaving my roots and my family in the Philadelphia area, but I loved my wife's family, and they were from Southern Virginia, so I was leaving one family and joining another, and taking the opportunity to build something at Wake Forest. And when I first got there, we had 9 operating rooms and 2 other rooms, one used for TURs and the other one for cystoscopy. So there were sort of 9 types of operating rooms and 300-bed hospitals. I mentioned I was the 5th person on the faculty. We had 1 or 2 residents, as I remember, and there was a school of nurse anesthesia, which is still there and had been there for many years. And Tom's emphasis was to get the clinical end going, to provide the service, to take care of patients. And my role, along with that, was to be involved with the medical students and to begin to interest them in the career in anesthesiology, because we felt well, there's no way we were going to really attract people to come from other places to Bowman Gray School of Medicine to do residencies, that we'd have to grow our own people from our own medical students. And so that was my assignment really for the first several years. And I was really affirmed in that I got the golden apple for teaching excellence from the senior medical students, both in 72 and in 73, and citations for teaching excellence in 73, 74 and 75, and then went on sabbatical leave for a year in England and didn't have as much emphasis on medical students. But with that, we were able to build up over time the residency program, and by the time Tom Irving stepped down from being the chair, which was the end of 1982, we were providing excellent clinical care and had a strong residency program and a lot of buy-in from medical students. And the 5 years before that, I had been over at Forsyth with our consolidated obstetric suite, where all the deliveries in the county were placed, and I think that first year we had 4,100 deliveries, which is a lot. And our medical school faculty provided the anesthesia for all of the obstetrics, both for private practitioners and the medical school faculty and residency program. And we also did most of the elective gynecology in that suite. And I had not anticipated on being a chairperson at all. And there were only a few places I really would have been interested in. And along came an opportunity to go to Chapel Hill because Ken Sugioka was retiring. And I ended up being offered that job and was trying to make my mind up. And Tom Irving said, after 15 years, I really was going to resign in another year, so I want to resign now. And then there was a search committee, and the dean at Chapel Hill was incredibly kind, Stuart Bondurant, and told me I needed to look at the job at Wake Forest, and if I ended up not doing that, they'd be happy to have me as chair at UNC. Being a real Demon Deacon rooter, it would have been very hard to become a Tar Heel. At the same time, they've had a lot of success, so that would have been fun. But I ended up staying at Wake Forest because I felt like I could probably do more with that department than I could with a state-run institution department. And the other thing was that I really felt we'd built something in the obstetric anesthesia area, and I was really concerned that if I left and somebody else became the chair, I just didn't know what was going to happen to that, and I hated to see that jeopardized in any way. So I ended up becoming the chair in 1983 in January. Hadn't thought that as a reasonable goal, hadn't really had any interest in that, but being head of the section of obstetric anesthesia did give me a lot of administrative experience, which was helpful.
Well, let me take you back to the beginning of obstetric anesthesia at Forsyth Hospital, and tell us a little bit about the practice at that time, the practice as you inherited it, and then the practice that you saw develop over a few years as you led that section.
Jim, that was really interesting, and I'm going to back up a little further because I think it's pertinent. When I first came to North Carolina Baptist Hospital and the Bowman Gray School of Medicine, it was the summer of 1968, and probably 85% of vaginal deliveries were done with general anesthesia, using cyclopropane and masks for managing the airway as opposed to intubating the patients. And we moved on from that, even though we had a lot of resistance, because it had always been done that way and everything had worked out well. There had never been any complications. And then maybe 6 months to a year after I got there, fortunately I was not involved in either case, but we had 2 cases of aspiration of gastric contents during general anesthesia with cyclopropane. Both patients did well ultimately. One was a patient, private patient of the man who finally became the chair of obstetrics, Frank Grice, and the other one was a service patient. So it really got the message across. And we were finally able to say, as the anesthesia folks, if we do general anesthesia, we're going to use endotracheal tubes. And the obstetricians thought that was just a terrible thing, to put an endotracheal tube in a patient. You know, why would you do that? So they backed off and did mostly pudendal blocks, some saddle blocks. We were doing very few epidurals at that time. And when we moved over to Forsyth for the consolidation, which was in November of 1977, so we're looking like 9 years after I'd come to North Carolina, it was, again, culture shock because they did not have any epidurals available there. Their anesthesiologists in the main operating room never came up to the labor suite except on very rare occasions when there was a serious emergency. It was mostly what was called prepared childbirth with, I'd have to add in, a lot of intravenous analgesia and sedation. A lot of people doing prepared childbirth education and teaching patients that epidurals were bad, that they might hurt your baby, they might stop your labor, you wouldn't be able to have the strength to have a spontaneous delivery, you'd have to have forceps delivery, and a lot of negative information, mainly because if you wanted an epidural, you were going to change hospitals and go to the North Carolina Baptist Hospital before the consolidation. We also had the issues of, since anesthesia had not had a real presence on the labor floor, the obstetricians being used to being in real control, and we had some very hard times with a couple of the obstetricians who did everything to obstruct us, and there's one I can think of in particular who ultimately became probably the department's biggest advocate, but it took time in which he saw the value of having anesthesiologists there and present. That first year, I think our epidural rate was probably maybe 30%, and it was kind of like being in the country of India and having the tame elephants who tried to and worked to educate the wild elephants that were captured so that they could be used for purposes of labor in the Indian environment. And we had our obstetricians who were the tame elephants, meaning the obstetricians from the medical school, who helped the private practitioners also understand what we could provide as anesthesiologists. And so it rapidly grew, as you know, Jim, to the point where 90-some% of the patients having vaginal deliveries have some sort of epidural or combined spinal epidural analgesia for delivery, and for cesarean sections it's virtually 100% regional anesthesia as opposed to general anesthesia at Forsyth, and before it had been mostly general anesthesia. So huge changes, and I think an excellent demonstration of how medical school can blend with a private practicing hospital and everybody can benefit. Instead of being arch rivals, you can really come together for the better treatment of patients.
So Frank, during that time you were also involved in research, both in the laboratory as well as clinical research, and some of those studies have had a tremendous impact on the practice of obstetric anesthesia. I'm specifically thinking about vasopressors in the treatment of spinal anesthesia-induced hypotension. And I know that was in relation with an obstetrician, and I wonder if you could tell us a little bit about your involvement in research and how you expanded that within the department.
In talking about why I chose to come to Wake Forest as opposed to staying at the University of Pennsylvania, actually an obstetrician, again, Frank Grice, was influential in my coming to Wake Forest because I knew that Frank had been doing studies with hypotension secondary to spinal anesthesia and what that did to uterine blood flow and some ideas about how to treat that. And what he was doing was primarily giving large amounts of intravenous fluid to see if he could expand the intravascular volume and treat or prevent hypotension that way. There's also an interesting story there in that Frank was making use of an electromagnetic flow probe which was developed by Carolina Medical. I believe Don Johansson, who is an engineer, has a PhD, and was not connected with the medical school, was involved in the development of that flow probe. And Frank used it on the uterine arteries of a chronic sheep preparation, which he had developed to study uterine blood flow. And it's, again, demonstrative of how things that you do in research can translate into actually helping clinical care. That same electromagnetic flow probe subsequently was used in carotid artery flow and in coronary artery bypass surgery flow on venous grafts in order to determine how well they were working after it had been developed and used in the sheep. So I knew Frank was involved with looking at aspects of anesthesia and how that relates to the pregnant patient. A little bit embarrassing that it was an obstetrician doing that and not somebody from our own field. So I did have the opportunity to work with Frank, and one of the things that we did was to look at the use of ephedrine as opposed to a purely alpha adrenergic type of agent such as neosynephrine. And we also looked at, again, increasing the vascular volume and some other things involved with spinal anesthesia and sheep. And it was really wonderful working with Frank, and I think it helped us to also mesh clinically because of the time we spent together in the lab. And for me to get to know him better, Frank, wonderful guy, feisty, very impatient. He always wanted to have done what was scheduled for a week from now, 2 weeks ago. Some funny stories that I could tell you about him, but we're not here to talk about that. But a good person, and he subsequently became the chairperson of obstetrics and gynecology at Wake Forest. He was one of the initial people in the formation of the Society for Obstetric Anesthesia and Perinatology, one of the not too many obstetricians who played a big role in that organization. So Frank, through my association with him and his encouragement of me to be involved in SOAP as it was forming, he was the one who made me aware of it and got me involved. So a very important person in my professional life.
So you're not one of the founding fathers of SOAP, but you got involved very shortly after it started and hosted one of the very early SOAP meetings in Winston-Salem.
There were 6 people who got together and really decided how to go about things to get the society started. The first meeting I attended, I believe, was probably a year or so later in Kansas City, and Bob Husted hosted that. Bob Husted of Husted Needle fame for epidural needles. And I can remember the issues at that meeting, primary issues were how do we get our foot in the door of obstetric suites? How do we gain the respect of the obstetricians? How can we help them to understand how we can help their patients and thereby help them, and so on. Also some of the economic issues, because reimbursement for obstetric anesthesia was really not good at all, which when you look at the economic issues and you look at academic departments, didn't exactly get chair people to be interested in supporting obstetric anesthesia because it cost money to do so. So those were the early days, and I think we had fewer than 75 people at that first SOAP meeting. And you look at the organization now, and wow, I mean, 500-600 people. And I have to say, I did ultimately go on and be president of SOAP, and that was being involved in that organization and being in the leadership was one of the highlights, big highlights of my career. And then to have David Dewan, who became the section head of obstetric anesthesia at Wake Forest after I became the chair, went on and became president of SOAP, and now we have the current president of SOAP with Bob, and am just so happy to see our involvement as a department in that organization.
So when people talk about Frank James, and this has been true since I've known him in '85, the word that comes up is gentleman. And I bring this up in the context of SOAP because I started going to SOAP in 1984. And it was clear from the first meeting I went there that there was a sort of a family feeling, a friendly feeling, a supportive atmosphere about this organization. And as I got to know Frank better, I think that it reflected in part his personality. So I want to ask you, Frank, why is it that you're a gentleman? Why is it that that stands out, I guess, to people, and where did that come from?
Wow. That's an interesting question. I guess it has to start with upbringing and the examples my parents set. I felt they, especially my dad, always treated people with respect and with dignity. And also, I think, to some extent, my religious background. My dad's family were all members of the society, well, at least on the paternal side, the Society of Friends or Quakers, and I think there's some gentleness built into that. Also, mentioned my older brother. He became a surgeon, and he demonstrated the attributes of actively aggressive, and I'd have to say I'm probably like a lot of anesthesiologists, more passively aggressive, but I learned what not to do from him. So putting all those things together and then having some teachers in high school who were wonderful role models of that. I can think of Clayton Faraday, think of Howard Comrie, a history teacher, some of my coaches actually in athletics, and seeing how they behaved and their being role models for me were very formative in that. And Jim, I'd like to go back too to the attitude at SOAP, because I think that was there from the start, and one of the wonderful things about the organization, there were people who were well established in obstetric anesthesia when I was just starting out, people like Gertie Marks, Saul Snyder, Mike Finster, June Morishima, who worked with Mike. She was not a physician, she's a PhD at Columbia, now retired, but all just wonderful people. And if you presented papers at SOAP, there would be questions, there would be critique that went on, but it was done in a supportive way to help you to be able to refine your study or to maybe take a different direction in what you were looking at. And it encouraged people, and I think it made people feel comfortable in speaking up. I attended some other subspecialty areas and sub-interest groups during my time at the ASA and other places, and I can remember going to some of them in muscle relaxants, and I thought, there's hardly any way I would get up in front of this group. They are really nasty to each other, and I never saw that in the Obstetric Anesthesia Society, and I think that was huge.
Another area you've been a leader is in the American Board of Anesthesiology, and you were an examiner and then became a director and eventually president of that organization. And I wonder if you could tell us your impressions of the ABA and the oral examination process specifically when you first got into it, and how it has evolved over the time you've been involved with it.
When I first got into it, we already were in a position where the questions that you ask were structured questions formed by a group of people who actually wrote the questions for the oral examination. And so you had guidelines and an outline that you really had to follow. Obviously, depending on how the examination was going, it could take a bit of a different path, but you had a uniform STEM question going on in all rooms in each of the 2 periods each candidate had. When I took my oral examination, which was in October of 1968, the examiners could ask anything they wanted to, and there were 2 rooms, there were 2 examiners in each room. I can remember still my 2 senior examiners, one was David Little, and the other was Frank Moya. Frank Moya didn't ask me a single question related to obstetric anesthesia, and I'm sure he didn't have any clue that I had an interest in obstetric anesthesia at that time. He wouldn't have known me from Adam. But it evolved over time to a really refined process that continues to evolve, and most specialties have dropped the oral examination, partly because of expense and number of candidates who come through. American Board of Internal Medicine, American Board of Pediatrics have dropped theirs just this year now. I don't know if they're giving an exam this year, but they will not be giving an exam in the very near future. An oral exam would be the American Board of Neurology and Psychiatry. So anesthesiology remains one of the few boards. Certainly some discussion about should this be done with simulators as opposed to an actual formal question-answer type session. What is the value of the oral examination? And sometimes people will say, well, the individual's in a stressful situation and how they're going to respond may give some indication of how they would respond in a crisis situation in an operating room. Others would argue that they're both very stressful, but they're not the same kind of stress, and they probably aren't comparable type of situations. But for now, at least, the American Board of Anesthesiology continues with the oral examinations. I was elected a director in 1989, and I can still, certain events in your life you can remember where you were when they happened. Like, I can remember where I was when the Japanese bombed Pearl Harbor, and I can remember where I was and what I was doing when I got the call from the directors of the American Board of Anesthesiology saying I had been elected a director. And it was a wonderful period of 12 years when I saw how hard the directors work to make decisions, how much discussion takes place, how much thought there is in making decisions, how they're very careful in considering the impact that their decisions will have on the candidates, on the people who are board certified, on patients. There's a lot of thought involved in the whole thing, a lot of consideration. If they make a major decision, they actually won't implement it until they've waited 6 months and come back and rediscussed it. And sometimes they have different feelings after they've had time to digest what they've decided. So it's a very, very good organization which tries to get representation, broad representation throughout the specialty from different areas such as obstetric anesthesia, pain management, general anesthesia, etc. I also feel that there are a lot of ethics that are practiced there and a lot of work to better care for patients. Just a great organization. The two things that I enjoyed the most, I think, on my time on the board were being involved with the Residency Review Committee for Anesthesiology, part of the ACGME, and heading that up for 2 years, and also being involved on the American Board of Medical Specialties and actually being in their executive committee for 2 years. And both of those things evolved out of being a director. That's why I was on in the positions I was in those two organizations. And again, the board has influence in those ways. It's different than the ASA. They're both terribly important in the specialty.
So let me ask you, the ABA is an important organization and makes important decisions for our specialty. It operates in a fairly transparent manner in some ways, but it also is behind closed doors, and a lot of decisions have to be made behind closed doors. There aren't a lot of things you can tell us, perhaps, but I wondered what the key issues were during that 12-year period of time that you were a director that you'd like to tell us about, and how the ABA grappled with those in the development of our specialty as they form it.
There were a number of key issues. One of them was qualifications for taking the examination, the written and the oral examination, and I'm thinking particularly of foreign medical graduates who may have received training in other countries, such as Canada or Great Britain or the Middle East somewhere or the Far East, and there was a period of time when if one had completed the training in Great Britain and you had a fellowship in the Royal College of Anaesthetists in Britain that you automatically qualified to take the examinations to be board certified in this country. And eventually the decision was made to eliminate that, and that was a long and a difficult time of decision making. Another thing that was difficult that I can remember was when the Society of Pediatric Anesthesiologists decided that they would like to seek accreditation through the Accreditation Council for Graduate Medical Education for training, subspecialty training in pediatric anesthesia. The board didn't have a direct decision in that, but we did have 2 of the 6 members on the Residency Review Committee. There were 2 appointed by the American Society of Anesthesiologists, 2 by the American Medical Association, and 2 by the American Board of Anesthesiology. And although as a member of the Residency Review Committee under ACGME, when you are on that committee, you're wearing the hat of ACGME and not the AMA, the ASA, or the ABA, it can't help but have some influence on your thinking depending on which organization was your parent organization and put you onto the RRC. So that was a major discussion within the American Board of Anesthesiology, and part of the consideration was if the Society of Pediatric Anesthesia does achieve accreditation for their training, what is that going to mean to practitioners in some of the smaller hospitals with 5 or 6, if they're lucky, anesthesiologists, and maybe no one who's done that kind of training, and then there's a problem with a 10-year-old child having an appendectomy, and what are the implications now when it's said, well, you didn't have somebody who had gone through accredited training in pediatric anesthesia on your staff, and that's why there was a problem. Those sort of issues get out there. The other thought was, if they achieve accreditation, will they then subsequently ask for certification through the examination process of the American Board of Anesthesiology? And a lot of talk, a lot of reassurance that that would never happen. I'm not cynical, but I kept thinking, you know, I'll buy the Brooklyn Bridge too if you have me believe that. And of course now we have board certification for the field of pediatric anesthesiology that ultimately did get requested and did get approved about 10 years later. One of my concerns there was that once you have that, then, and we already had it in pain medicine, we already had it in critical care, and there were other reasons for that, but what about obstetric anesthesia, cardiac anesthesia, neuroanesthesia? Would they all then, since they all had fellowships, seek the same kind of accreditation and board certification? And of course that's happening, which is a fragmentation, I think, of, and that's my own personal view of our specialty in many ways, and is worrisome.
So I want to ask you a couple questions about your accomplishments as you see them looking back on your leadership positions in anesthesia, and then a little bit about your personal family history, and then end up with some challenges that you see to our specialty. So in thinking about accomplishments, we've talked about both national and local positions that you've held and issues that you've dealt with. What do you think have been your most important accomplishments, both locally within a department and a medical center, and nationally and within the specialty?
I guess it was a year or so after I stepped down from being the chair. I did that in the summer of '98. I was serving as a consultant for a group out of Philadelphia which wasn't related to anesthesiology per se. They tended to send people as consultants to areas where there were problems, and it could be a problem in internal medicine, it could be in obstetrics, whatever. It could, in this case, it was a private practice in anesthesiology in another state where there were some concerns about were the anesthesiologists living up to what they'd agreed to in the contract they had with the hospital. And I was there with another person from an academic, 2 other people from academic departments, one from the Northeast, one from the Northwest. And we were coming back from our day of interviewing one day, getting ready to go to dinner, and they said, why would anybody ever want to be head of an anesthesiology department? In this day and age, things are so hard. They've always been hard, I believe, and they always will. There will always be challenges. They're different challenges from one decade to the next. But what I said to them was the two things that I felt were most rewarding to me and made it worth it were, one, the residents, and taking people who come into the residency pretty frightened, pretty ignorant as far as what goes on in anesthesiology, and leave really with more information and more technical skills than anybody on the faculty, because they've taken the very best from each person in the various areas of the practice of anesthesia within the department. And they've grown and they've matured. So to watch them grow and to watch what they do when they finish, whether they've gone into private practice or academic medicine, just incredibly rewarding. The second reason I gave that I really received great pleasure and view as an achievement was to see faculty development and to see what happened to people after they came in. And Jim, I'm going to give you a compliment here and say there were some, it was just a matter of getting them pointed not even in the right direction because they already knew where they were going to go, but really just trying to provide an environment in which they could thrive and do their thing with really virtually no input from me, but some support from me. And then there were others who maybe had a little trouble focusing on just what it was they wanted to accomplish and eventually just took off. And I'm thinking of one of your colleagues in obstetric anesthesia, Madge Owen, who, with her having focused on forming Kybella, a foundation that has as its work improving the care of women in the period around the birth process and outcomes for their newborns in countries where that care has just been virtually either not there or extremely primitive. And she's had an impact throughout the world and has volunteers from Australia, from Ireland, from Great Britain, from all over the United States who help her with that work, and has done wonderful things in Turkey and Ghana and Mongolia, Ukraine, Georgia. I joke about Georgia when talking about that and say it's the one over there in Europe, not in southeastern United States. So you and Madge are just two different examples, but I can think of so many faculty people who I've watched grow and achieve, and we've had a total of 11, as I tried to count them up earlier today, people from the department who've gone on to be chairs at other departments, and that too has been extremely rewarding to watch. I think within own department, I look at the growth of it, where I came there and I was the 5th person on the faculty, and Tom Irving really wanted to grow something. We had 26 faculty members when I became chair of the department in '83. When I stepped down in the summer of '98, we had 42. And now there are over 70. I mentioned earlier we had 11 operating rooms and procedure rooms at Baptist Hospital. There are now about 45. The hospital itself has gone from 300 beds to about 1,000 beds. So huge changes there. And within the department too, the consolidation of obstetrics at Forsyth Medical Center with the cooperation of Wake Forest University Baptist Medical Center and Forsyth Medical Center in doing that, and something that's really been of great benefit to patients, that also has been extremely rewarding to me. I think another thing that I would say that's been rewarding in retrospect is the things that I've learned throughout my career in anesthesiology have translated into what I've been able to do after retiring in the way of community involvement, and the skills you learn, the experiences you have can easily be transferred to other activities within the community, and you can remain useful and benefit other groups and organizations. And one in particular has been incredibly rewarding to me, and that is a nonprofit agency that grew out of the Johnson Great Society era. It's a community action agency in East Winston. It's now about 45 years old, and their mission is to help the working poor to become self-sufficient and to be contributing members of society. And it's really heartwarming to see some of the stories of some of these folks and where they were and what they're able to do now. So again, I think what what physicians can learn in their time in the practice of medicine can really help them later in life to continue to contribute to their community and other people.
So Frank, it's interesting that when I ask you about accomplishments, you talk about other people a lot and other organizations rather than what you personally have done. You have been honored locally as well. There's a lectureship in your name and there's a chair in your name. And I wonder if you could just tell us a little bit about those and how they came about.
Well, the chair came about because our department, during the time when I was chair, fortunately, and it didn't have a whole lot to do with me, it just had to do with the era. It was a wonderful time for academic medicine where you were actually able to have a positive line, bottom line, when it came to money coming into the department. And departments at Wake Forest were able to put money into their research and development fund, which the dean always maintained belonged to him, but kept hands off. And we reached a point where we had enough money in there to endow a chair, and the department decided that we wanted to do that, to take the money out of our research and development fund. And I think at that time, Jim, it was something like $1.2 million at Wake Forest to endow a chair. And so the department voted on that, and then subsequently decided they wanted it to be named after me. I don't want to say I'm embarrassed. I was deeply honored by that. I hadn't expected that, certainly hadn't thought about that possibility at all. So that's how that came about. As far as the Frank James lectureship, that's something that the folks in obstetric anesthesia, they came up with that idea where a visiting professor will come, sponsored by the department, and give a talk, and they give that talk to both the private practitioners and the academic departments of obstetrics and anesthesiology. And for years that was held over at Forsyth. I know the last couple times they've done it over at Wake Forest. But that's been a fun thing for me because I've been able to reconnect with some of the folks that I've known throughout the years in obstetric anesthesia as they come back and get to see what's going on at our place, and we get to learn from them. So that's been a lot of fun.
So as a segue to the future, what you see in the future and the challenges to the specialty or our society, tell us a little bit about your family and your children.
Well, my wife of 50 years come the 25th of next month. I met her in college. She was a freshman my junior year. She'd come from the South, and I joke and tell her I've always been attracted to women with foreign accents, and with her South Virginia accent, that qualified as a foreign accent at Swarthmore College, and we began to date the second part of my junior year, and then she transferred to Randolph-Macon Women's College in Lynchburg, Virginia, now Randolph College and coeducational. It was a women's college when she went there. But we had off again, on again relationships until she moved to Philadelphia after finishing college. And when she threatened to go to California, I decided I'd better ask her to marry me. So we got married, and we have 3 children. Oldest one lives in Philadelphia, and she has been very interested in the arts. She's pursued a career in modern dance, had a small dance company in New York where she lived for 11 years. Subsequently came back to the University of North Carolina at Greensboro and got a Master in Fine Arts in the concentration in choreography, and now is back in Philadelphia pursuing both writing music and doing choreography. I think that comes from my wife, who's a very creative individual. She both is an excellent writer, and now for the last 5 to 7 years has been doing watercolors and has been very successful and creative in that. Second daughter, more like her dad in some ways, and ended up going to the University of Michigan to law school, practiced law for 4 years. Then went to Duke to medical school, UCLA for a residency in psychiatry, and she practices psychiatry in California at this point. She was married for 10 years, but they were unable to have children, and now she's practicing in California. And then our son does portfolio management and has a wife who's an attorney. They live in Winston-Salem, and they have our 2 granddaughters who are now 17 and in a few days 14. So that's pretty much my family. I did want to say one thing, Jim, too, about the formative years. I was very fortunate between my junior and senior year of medical school to do a surgery fellowship in Edinburgh, Scotland. And I worked with a fellow named Professor Woodruff who was doing early work on kidney transplantation, doing work in dogs. And associated with that, I spent time in the operating theaters working with J.D. Robertson, who was a professor of anesthesia at the University of Edinburgh. And he worked at the Royal Infirmary. And I saw what an anesthetist, as they would call them, could do, the respect that the surgeons had for him, and the skills that he had. He taught me a lot. He was interested in having me there, and that sort of keyed my interest in the field. My dad had dabbled in doing some extra training in anesthesiology after he'd finished medical school, and that keyed some interest. And then in, I guess it was 74, 75, I had the opportunity to go back to England to do a sabbatical with Selwyn Crawford, or Jeff Crawford as he was known, at the maternity hospital, which was part of the University of Birmingham's system. And we worked a lot looking at epidurals, since they were used so commonly in labor and delivery there, but not in cesarean sections. And again, that was a wonderful period of time, and there were a lot of problems first at Baptist Hospital and Bowman Gray in getting the obstetricians to really believe what you said, because you were there, and you know, what did you know? But if you could go away for a year and then you could come back and say, well, I saw this, I did that, I saw how things can work out, you had more credibility. And so it helped me both academically and I think clinically to have spent that year. And then, of course, a few years after I came back, the consolidation came about at Forsyth Hospital. So those were formative times in my life. And then I have to also mention Tom Irving, who was first head of the section of anesthesia in '67 and chair of the department in '83 when I took over. He was a real role model of saying never promise what you can't deliver, which I thought was incredibly important, and being honest and open with people. So Tom deserved a lot of credit, and he interested me in anesthesia because although he thought he wanted to be a psychiatrist during his internship, he switched over to anesthesiology and kept telling me that's what I should do. And I was in the Air Force at the time, and actually spent a third of my time delivering babies, and the only anesthesia we had available was either pudendal block or spinal. And so that, along with my experiences in obstetrics at Philadelphia General Hospital as an intern, got me thinking we can do better by women in labor, and all that put together got me into obstetric anesthesia.
Wake Forest University does have a sabbatical policy, but it's not terribly supportive financially. And one of the things that Frank did was to support individuals to do sabbatical leaves if they wanted to. And I want to ask you just a little bit about that, since you raised the sabbatical period. Tell us a little bit about what that meant to your family and what the practice of obstetric anesthesia was like in '74, I believe you said.
74, 75,
Right.
Summer 74, yeah.
In England.
Well, I can say what it was like at the maternity hospital in Birmingham, because that's where I was focused, although I did spend 4 or 5 days working with Donald Moyer and really observing, I won't say working with him, up in Glasgow. And I'd say he and Jeff Crawford were really the two giants in obstetric anesthesia in Britain. And it was really interesting because they were far advanced in comparison to us when it came to using regional anesthesia during labor and delivery. But it was pretty amazing, some of the practices. For example, a large number of the deliveries were, well, I guess I'd have to say elective, in that they brought people in and actually established the epidural anesthetic and then ruptured the membranes, and if they didn't go into labor within about half an hour to an hour, began an oxytocin infusion. And they don't do that any longer, but about a third of the deliveries had an induced delivery that way. They weren't using any spinals or epidurals for cesarean sections. It was all general anesthesia. So those were two real differences. And talking about differences, Jim, it was pretty amazing to watch them do general anesthesia for vaginal deliveries without an endotracheal tube, using a combination of cyclopropane, nitrous oxide, and oxygen in a system which allowed a lot of that to escape into the room. And having grown up using cyclopropane as a resident and understanding that it was incredibly explosive, I was very uncomfortable being in that delivery room, seeing what was going on. Clearly they had not had any problems, but it was still a very interesting and somewhat frightening experience to be there. Something else that I really learned from Jeff Crawford was the fact that if you are present in a labor and delivery suite, just by the fact that you're there, and lots of times staff obstetricians are not there, by default you will be the person to whom obstetric trainees turn to for advice as things are progressing or not progressing in a labor and delivery situation. He, in the British system, worked really hard. He got there at 9 in the morning and he didn't leave usually till around 6 in the evening. Never came in on night call. In that system at that time in Great Britain, the consultants did not come in. It was all done by the registrars. It was very much a see one, teach one, do one type thing, with very little input from teaching staff at the maternity hospital along the way for the registrars. And that was a huge difference. I think we felt in the United States much more compelled to supervise residents very closely. But Jeff's continuing presence in his office and in that suite was really important. And that transferred over to Forsyth when our faculty began to be there full-time, 24 hours a day in 77. Again, lots of times the obstetric house staff looked to us for advice, and that was important.
Well, I know that you also, Frank, instituted and supported education of obstetric residents in the anesthesia department when you talk about communication, because when I came, they were spending 2 months of their first year as anesthesia residents, learning about the problems we face and the limitations that we have.
That was, I thought, a wonderful part of what happened for a number of years. And when those obstetric residents came through the time with us in anesthesia, they first spent time in the general operating room to learn how to manage airways with a mask and with oral airways, and how to place endotracheal tubes, and some of the ins and outs of general anesthesia, and some skills with regional. And then they spent, actually it was 3 months initially, they spent the subsequent 2 months on labor and delivery. And it was wonderful because they learned our point of view, they learned the problems that we faced as anesthesiologists. They learned about the importance of communication between obstetrician and anesthesiologist, and that resulted in good working relationships with those individuals as they progressed through their residency in obstetrics and gynecology. Ultimately, that got pared down to 2 months and then 1 month, and I believe it doesn't even exist anymore. And that is through no fault of anything locally. It was the residency review requirements in obstetrics began to require more and more things of them, and so elective time and time to spend in anesthesia became less important and eventually disappeared. And I think that's to the detriment, really, of ultimately patient care.
I'm intrigued with your comment about cyclopropane nitrous oxide for vaginal delivery. And not having lived in the cyclopropane era, I've heard stories about the wonderful rapid qualities it had. So walk me through what a cyclopropane nitrous vaginal delivery, perhaps with fundal pressure, might look like.
It might look like scary to you is the way I would answer that. One of the virtues of cyclopropane was it acted incredibly quickly, so that after 1 or 2 breaths, the person really wouldn't be aware of what was going on. It took a little bit longer for them to become anesthetized. but it was a very potent anesthetic agent. The second thing was that you could give very high concentrations of oxygen with it, anywhere from 80 to 90%, and sometimes even a little bit more oxygen. So it was very helpful in keeping patients well oxygenated during the case. It was explosive, and a person with whom I worked both as an intern, not on her service, but came across in the operating room, Margot Van Demming, who was Dr. Drips's first resident in anesthesiology at the University of Pennsylvania, left there and worked at the Philadelphia Children's Hospital, and she was involved in an explosion with cyclopropane, and if I'm correct in remembering this, it was before I got there, but I believe the patient did die, and she was incredibly sensitized as to the dangers of cyclopropane, and I made the mistake as an intern of actually taking a metal patient's chart off of her anesthesia machine without saying anything to her or without touching her first, and the idea there was that you didn't want static electricity to spark an explosion, and needless to say, I terrified her when I just took that off the machine, and she bit my head off. One of my scarier moments as a resident was when I was a CA1, I guess you'd say, and faculty, as I mentioned earlier, didn't come in, and we had a case going on with another CA1, which the CA2 was supervising, and all of a sudden there was a breech delivery on labor and delivery, and the rationale at that time was, at least with this one obstetrician, I want you to give cyclopropane anesthesia just as the woman's getting ready to deliver the head, so it will relax the cervix. And we subsequently have learned that cyclopropane doesn't relax the uterus at all. But I induced general anesthesia with a mask, and the baby was delivered, and the baby did well, and I really caught hell from the senior resident because I'd gone on with that anesthetic and not waited for him to get there. Well, there was no way he was going to get there in time. It was all on the same floor, but he had to come a couple buildings away, and who knows if he, I mean, we didn't have pagers and things that we have now that you could get a guy immediately with, so that was pretty scary, but the obstetrician actually defended me and went to Dr. Drips and said how much I'd helped him and everything, so it was scary to do the anesthetic, and it was scary because of how the senior resident felt about me, but that was a cyclopropane story that ended up being a happy one, and part of the reason it did it was just induce general anesthesia so quickly that the woman relaxed, and then the obstetrician could work to deliver the baby. It was a wonderful agent, and I'm very grateful for having done my anesthesia residency when I did. When I started in 1964 at Penn, that was one of the few institutions still using ether anesthesia, and as a beginning resident, you had to learn to do a gas oxygen ether induction with a mask and to maintain mask anesthetic even for cholecystectomies. And we wouldn't want to do that now. I wouldn't want to supervise somebody doing that now, but you really learned how to manage an airway, how to manage all the things that can occur during induction, such as patient regurgitating or vomiting, patients salivating tremendously, patients developing laryngospasm. I mean, things that were really scary, but you got the experience in managing them, which was helpful when those things did occur later in life. From that, we graduated to using nitrous oxide oxygen and trichloroethylene, which was another interesting situation where ultimately we would give intravenous narcotic to slow down the tachypnea that had developed with that particular combination, and I guess if we could have measured pulse oximetry in those days and some other things, we might have been pretty amazed at what we saw. And then finally, after you'd been a resident for about 9 months, you were allowed to use halothane, and we weren't allowed to use it earlier because it was so easy compared to the other things that they knew you wouldn't want to use anything else. And Penthrane also came in during that time, so I got a lot of experience with a lot of those agents, which I think gave me some skills that I'm afraid, although not needed a whole lot now, people don't have, young faculty don't have, and residents don't have, particularly when it comes to airway management with a mask. And thank goodness we have the laryngeal mask anesthesia instrument now, because it really does do wonderful things. But there are still occasions when you may not have those things available, and you might need to maintain an airway with a mask, and I worry that that's one of those lost skills.
You also served as a leader in obstetric anesthesia through the time in the late 70s, early 80s of the two key toxicities associated with epidural anesthesia. That is cardiac arrest with bupivacaine and neurotoxicity from 2-chloroprocaine. And I guess the practice of obstetric anesthesia changed fundamentally between 75 and 85. And what were those changes as you saw them?
Well, I think increasing refinement of the types of regional anesthesia during labor and delivery. And I will back up and say, when I was talking earlier about our coming as an academic department into what had been a totally private practice arena at Forsyth Hospital and trying to blend the two types of practice, that we saw a number of things that were beneficial going in both directions, and the fact that they had had so much prepared childbirth and women were so attuned to having a baby without anything meant that we could give a different type of epidural analgesia in that the patients didn't expect to be without sensation. They wanted to feel contractions. They didn't particularly want pain, but they wanted to have enough motor strength to be able to continue to bear down and deliver spontaneously. So I think that educated us in how to give an anesthetic during, or analgesia during labor, that kept the woman more able to participate in the delivery. And I think throughout the field of obstetric anesthesia in general, we saw a progression of that with smaller and smaller doses of lower and lower concentrations of local anesthetic, the addition of small amounts of potent narcotic with that analgesic or local anesthetic agent, and the blending of those and how that could really facilitate labor and delivery. And then the reemergence of spinal anesthesia also, as smaller and smaller needles of with different types of points, such as the Whitaker needle, the Sprott needle, and so forth, came along, and then the idea of the combined spinal and epidural was another advance. So refinements of the types of labor analgesia. When we first went to Forsyth, and I believe this was before you came there, Jim, one of the types of regional we did, Scott Wheeler, who had been at the Portsmouth Naval Hospital before he came to join us on the faculty, introduced lumbar sympathetic blocks. And we used those during labor, and they provided incredible analgesia. They were difficult to do, I think pretty darn painful for patients, because it was not an exact science, and it was a couple of needle sticks in the back, which I think were not too comfortable for patients, but they did get almost immediate, incredible pain relief. Also, an increase in uterine activity, which could facilitate labor, but could be scary if you had a patient who already had an irritable uterus. So we tried to stay away from using that analgesic agent when it came to somebody, say, with preeclampsia or toxemia of pregnancy, and ultimately, as epidurals became more and more accepted, we just didn't do lumbar sympathetic blocks anymore. We also saw the movement away from paracervical blocks, which were used quite a bit at Forsyth when we first went there, and of course the implications there for the baby were also not necessarily positive, and folks didn't understand that initially. So that was another change, and of course we did move away from 2-chloroprocaine and went to lower doses of bupivacaine. Again, going back to looking at differences in practice in Great Britain and in the United States, they did not have 0.75% bupivacaine, nor did they ever use 0.25%. They used all of 0.5% bupivacaine, and they also, when they induced epidural analgesia for labor, I was told they had no use for ephedrine, that the patients never became hypotensive when they had, give these doses to get them numb enough to have an amniotomy and induce labor if they didn't start spontaneously. And the reason that they didn't get a hypotensive was they didn't take the blood pressure, so they didn't know if a patient was hypotensive. Another thing that did change from the early times in obstetric anesthesia until later, and which again caused a lot of controversy at Forsyth, was the concept of left uterine displacement. We didn't understand that initially, and I remember as a resident, certainly we didn't understand that. And one of the times I got into a real knockdown drag-out at Forsyth Hospital was with the obstetrician I mentioned earlier, who was very much of an obstructionist and then later became a very strong supporter of obstetric anesthesia. He did not want me to tilt a patient during a cesarean section, and this patient, as I recall, was going to have a general anesthetic. I may be wrong on that, and there were indications for that. It was an emergency, and I just refused to induce anesthesia until we had the patient tilted, and he was going to call the hospital director, which I invited him to do, and of course he didn't do that. But he did not understand two things. It was a little harder, he thought, because he wasn't used to delivering a patient in that situation by cesarean section. And secondly, it was a control issue where he really wanted to be able to 100% say how things are going to be done. And the department as a whole struggled with that. And with time and patience, which again is something I think I've learned over the years, that if what you're supporting has merit to it, and if you're patient, and if you're persistent, very often people will come around and will see that point of view, but it takes patience and persistence.
Since you mentioned Scott Wheeler, I wonder if you could briefly tell us the rationale for writing a textbook. So you wrote a very influential textbook that went through a few editions in an early textbook in obstetric anesthesia, but there were textbooks before that. So what was the idea of presenting yet another one?
The idea behind that, and it was obstetric anesthesia, the complicated patient, was that although things like multiple gestation, breech presentation, preeclampsia were all abruption of the placenta, placenta previa, all mentioned in some of the textbooks on anesthesia, and Saul Schneider had an excellent textbook on obstetric anesthesia. There wasn't great emphasis on how to approach the complicated patient, and so Scott and I thought this would be something that we could contribute. We were seeing a large number of deliveries and had our own personal experience and departmental experience, and as we attended SOAP meetings and got to know other people, we realized there were many people around the country who could contribute chapters to that book. So that was the idea behind doing the book, and we learned a lot by doing that book, made some good friends by getting to know the authors of the various articles better. And then we did have a second edition, which came out about 6 years later, and by that time I had become the chair of the department and just felt like I didn't have the time to really be more involved in that type of an activity. I did, after I stopped being the chair, co-edit a British book, Principles and Practices of Anesthesia. That Dr. Peter Hutton was the primary editor of that, and Dr. Cooper, and then Dr. John Butterworth helped me on the American side, and that was interesting, and we focused on a number of chapters there, editing them that didn't necessarily have connections with obstetric anesthesia.
You mentioned moving on to a position in the dean's office related to graduate medical education, and I wonder if you could comment how that differed or what you learned from your leadership within our specialty that translated to a more general medical education.
I have to back up lots of times in saying how things came about. I decided to step down from chairing our Department of Anesthesiology probably around 96 or 97, and I did tell the dean at that time, Jim Thompson, probably a year before I really was going to step down, which was in the summer of 98, that was my plan. And that's a little dangerous in that you lose a little bit of your clout, I guess I would say, if they know that you're going to step down. But Jim never treated me that way. I felt he was always very fair and honest and open with me. And at the time I talked to him, which would have been in the summer of 97, I guess, he said, well, I'm thinking of creating a new position, and that will be the Associate Dean for Graduate Medical Education, a position that hadn't existed at the medical school before then. And Jim knew that I'd spent 6 years on the Residency Review Committee for Anesthesiology. He knew that as a result of that, I had been on the Residency Review Council for the ACGME and had headed up the nominating committee for 2 years and been vice chair of the Residency Review Council and so on. And so he felt this would be a good thing for me to do after I was no longer chair of the department. So when I stepped down in the summer of '98, and the reason I stepped down was that was 15 years of being the chair of the department. The department was doing well, and as you're getting older, you know, it's sometimes a pretty competitive game, and other chairs in recruiting your faculty people, in trying to recruit faculty people you're both hoping will come to your institutions, in recruiting residency candidates, will begin to say, well, so-and-so is going to retire in a year or two, you don't want to go there. It's sort of like a basketball coach. You want that coach to be there the 4 years that you're going to be on the team. So I thought, the department's doing well. I'm going to step down while it's doing well, and hopefully we can get a good person to come in and become the chair. And yet, it's going to be another couple of years till I'm really ready to retire. I was 62 at the time I stepped down and became 63 the following December. And so it worked out perfectly, because although I still did some clinical anesthesia, I could really focus on being the Associate Dean for Graduate Medical Education. And one of the big tasks that we had to do was to institute the practice of mock visits by the Residency Review Committee. And so therefore each department had to prepare program information forms just like they had to do for the RRC. And then after we'd had a chance to review that, have a mock site visit. And I did a number of those. I had some other people help me with that. And it was really very interesting, because just like in going out and reviewing anesthesiology programs, you found some chairs who were very welcoming, were appreciative of your pointing out where they were not in compliance with the regulations from their own specialty and what they needed to do to strengthen their department. It also provided some of them with talking points when they went to talk to the dean in order to get more in the way of resources, because those things were lacking and they were going to have problems when the Residency Review Committee came through. There were other chairs who were extremely resistant, didn't want to take any advice, didn't want to make any of the changes, and of course a number of them then had difficulty when they actually had their residency review. And it was surprising, because some of the chairs with whom it had not always been easy to work in the operating room were ones who were most receptive to constructive criticism of what was going on in their programs when you did your mock visits to them as an RRC. Others who had been really easy to work with in many other settings got very defensive about any criticism of their program, even though you knew that criticism was going to come in the real world when the RRC visited them. So I did that for the 2.5 years, and spent a lot of time. It was usually 2 to 2.5 days a week doing that. And a good thing about that was it allowed me to remove my focus from the department and not be present a lot, and to allow Ray Roy, who followed me as chair, to really develop things without any either implied or real interference from me. I really wanted to step aside and let him do his job, which is another reason that I took a sabbatical for 6 months after I stepped down as being the chairman in the summer of '98. And then Dr. Patricia Petroza, another success story as a faculty member, took over that position as Associate Dean for Graduate Medical Education, and she's still doing it. So it's now 11 years that she's been in that position and doing a great job with it.
You mentioned one of the community activities you've been involved with since you've retired, but I know you're involved in others as well, and I wonder if you could tell us a little bit about the main things you're doing.
Well, the Experiment for Self-Reliance was the organization I was talking about earlier, and this year I've been involved with Dell, my wife, and another couple, Dr. Larry Hopkins, who's an obstetrician on the medical school faculty, and his wife Pat, who's an attorney, we're the honorary co-chairs of the capital campaign, and it has been incredibly affirming to us to be able to go out and talk with people in the community. And you have to understand this is primarily an African American organization, but it does have some clients who are Caucasian, some who are Latino. But to talk to people in the community who have known nothing about the organization, and when they learn what it does, to see them put financial support behind the capital campaign and to actually go out and solicit other people to contribute, that's been wonderful. I've also been involved with another organization called Senior Services, and Senior Services has just an incredible executive director who's been with them probably about 20 years. Never does he take any credit for anything that happens that's positive in that organization. He's always thanking other people, either his staff or volunteers. Just within the last year, they've delivered their 4 millionth meal for Meals on Wheels. They deliver well over 1,000 meals a day. The governor came and helped deliver that meal, and a former governor helped deliver the 3 millionth meal a few years ago. They also do some medical care in the sense that they have certified nursing assistants who will, on a regular basis, go into senior citizens' homes and help them look at hazards such as throw rugs over which they might trip, to make sure they're understanding how they're supposed to take their medications, helping them some with bathing and so on. So that's another service they provide. Plus, they have a wonderful daycare center for people with mental deficiency, usually Alzheimer, and actually won the award for the best such unit in the entire country this year. So we've been involved with that. They're just coming up for a capital campaign starting in January, and Dell and I were chair of their annual fund a year ago. I've also been involved with the Arts Council, and that's been wonderful. The Arts Council this past year exceeded its goal. They have just finished what was a $26 million fundraising venture that raised over $27 million, almost 28, and that was in this economic environment, which I think is absolutely amazing. And I have just gone back on the board at Salem Town, which is a continuing care retirement community. It's a place where my mother did live for 5 years prior to dying, just short of 94 years of age. That's been 10 years ago. But it's a wonderful community where you can move into independent living either in a cottage, freestanding cottage, or an apartment. And as your needs become greater, if you have to, move to assisted living, and then finally, if necessary, to a healthcare unit. And it's a wonderful service. There are 3 or 4 such organizations in Winston-Salem, but I was on the board at Salem Town from '93 to '99, and now back on it again, and be heading up the medical community, or not heading up, but on the medical committee there for that. So that's been rewarding. And then there have been some medical groups. I'm on Medj Owen's board at Kybella. I've talked a little bit about what they do earlier. And then Rick Rauch's Scepter Pain board as well, which has been rewarding to see what Rick's doing in the area of pain medicine.
So I wonder if you could tell us a little bit about what you see as challenges to our specialty that are existing right now, and where you think we're going in the next few years.
I think there are a number of challenges. I think as the country looks more and more at the cost of medicine and how it's greater in this country than many other places, we're going to have to continue to make progress in delivering cost-effective anesthesia care in ways that sustain excellence in care for the patients. I think that we are going to have to continue to work to educate the public as to what an anesthesiologist does, what the educational background of an anesthesiologist is, and why it's important to have an anesthesiologist involved in their care. Tied into that is to help our legislatures to understand the importance of anesthesiologists. And if you're looking at costs, you know, there have been some steps out there to say we can use paramedical people, or paraprofessional maybe is a better way of stating that, to do the care of what is normally supplied by physicians, and that wouldn't be limited to anesthesiology with nurse anesthetists. We can see nurse midwives in obstetrics. We can see optometrists in the field of eye care, ophthalmology. We can see nurse practitioners in the area of internal medicine and family medicine. And these are all areas where alternatives to physicians cost less. And we have done such a great job in anesthesiology in reducing the mortality associated with anesthesia that many people feel that maybe we don't need anesthesiologists any longer. The practice of anesthesia is so simple and so safe these days. And of course that's an overstatement. By all means, it's not simple, and it wouldn't be safe without some of the developments that have occurred. And again, if I think back to your comments about what was it like when I was a resident, we didn't have end-tidal carbon dioxide monitoring devices. We didn't have pulse oximeters. We didn't have fiber optic instruments to help us with difficult intubation. So there were a lot of things that have developed that do make the practice of anesthesiology safer. So I think we have it cut out for us to help folks understand, both in the lay public and in the legislative areas, why we're necessary and what it is that we do. I do think, too, there are continuing challenges to refine and improve the practice of anesthesiology, maybe get us to where the death rate and particularly the morbidity rate are less and less. And the first paper I ever wrote, Dr. Drips at Penn gave me the idea to do it and said, why don't you do this? He said, I've had a number of executives come through and had surgical procedures who said they didn't think as clearly afterwards. And of course everybody thought it's the anesthesia doing that. So I did a paper involving the mental effects of cyclopropane anesthesia in people who were healthy and weren't having surgical procedures. These were 21, 24-year-old males, volunteers who were having cerebral blood flow studies done at Penn at that time, and we tied into that, since they're having it done under cyclopropane anesthesia, the effects on mental function. And there's still a lot of questions about mental function after anesthesia, whether it's heart-lung bypass machines and what's involved there, or just plain anesthesia procedures. And in my lifetime, I've had 17 operations, if you can believe it, and all kinds of anesthesia. So I'm very aware of the effects of anesthesia and the lack thereof, and think we can do a lot to improve things. And I will say something I've learned over and over again is the importance of communication, of anesthesiologists continuing to relate to patients and to work with patients, to add in just the human thing of touch, of letting them know you're there, of supporting them, helping them understand that you know that they're very anxious and stressed. That's meant a lot to me when I've been in those situations, and I've seen the effect it can have on patients, and that's something I did try to role model to our residents.
Since you are involved and have been involved so much in the community, I'll ask you a broader question, and that is, what are the challenges you see for society in general? You can relate it to medicine if you like, but that you see that we have coming up.
Well, I think one of the problems we have is people being able to talk to folks who have a different viewpoint and to listen to them and try to understand what it is they're saying, and to realize that they're not bad people just because they don't necessarily believe the same thing that you believe, and to continue to respect them, have them feel that you respect them as an individual even though you may disagree with them, and to have the courtesy to listen to them without interrupting and without being judgmental, and of course, having with that the expectation that they'll turn around and interact with you in the same way. I think certainly as anesthesiologists we can see that throughout our history with surgeons and with obstetricians, and I think we've made a huge amount of progress along those lines. I'd like to see more of that when it comes to our own government and people within our government with the different parties being able to work together. One underlying principle that that I always tried to keep in mind, and it was both in the patient care setting and in the administrative setting, is that if we as physicians could keep in mind the patient and work towards what's best for the patient, a lot of the controversy and conflict would go away, and a lot of the ego part of what we do would go away. And I think that, again, can be transferred over to politics within the United States and relationships within the world. So I think going forward, we need to improve that, and that's going to be a big challenge in all areas.
Well, thank you, Frank. It has been my real honor as one of Frank's many mentees and friends, and as the first Francis M. James III Professor of Anesthesiology at Wake Forest University, to document this contribution of a life to our specialty and to our society. I want to thank especially the Wood Library Museum for making this possible, and for its Committee on Living History, especially Dr. Bradley Smith and Dr. Marcel Willock.